Welcome to This Explainer. Today, we are diving straight into the deep end of outpatient cancer rehabilitation. We're going to unpack the clinical, cognitive, and psychosocial complexities of this field, and we'll be doing it through the lens of a gold standard occupational therapy case study. We'll see exactly how to integrate physical rehab with some pretty intense vocational advocacy. But before we get bogged down in the dense medical data and biomechanics, we really need to ground ourselves in the psychosocial reality of our patient. Meet Sarah. She's a 52-year-old full-time elementary school teacher. And right now, her entire professional identity is colliding head-on with her post-treatment exhaustion. She is absolutely terrified of failing her students. And honestly, that fear is just as critical to our treatment plan as any physical symptom she's dealing with. So, to navigate this complex scenario successfully, we're going to follow a 5-stage clinical journey. We'll go through referral and immediate priorities, clinical assessment and formulation, setting smart recovery benchmarks, the comprehensive OT intervention plan, and finally, managing setbacks. Let's kick things off with Section 1, Referral and Immediate Priorities. Let's look at the critical data we need before Sarah even walks through the clinic door. A thorough chart audit using the Canadian Practice Process Framework tells us a lot. Sarah had a left lumpectomy and an axillary lymph node dissection. This means her lymphatic architecture is permanently disrupted. She finished chemo 4 weeks ago, but she's still undergoing active radiation. This exact combination dictates some very strict safety parameters for us. We're looking at a lifelong lymphedema risk, potential cardiotoxicity, radiation-induced tissue fibrosis, extreme chemo brain fatigue, and systemic cytopenia, so things like anemia and neutropenia risk. Now, as a seasoned clinical mentor might ask you, what are the immediate red flags here? We absolutely cannot jump straight into exercise. We have to prioritize infection control first. An insensate or swollen limb is highly vulnerable to a rapid bacterial infection, like incipient cellulitis, which is a literal emergency. We also need to protect her active radiation fields from friction, shear, or any heavy creams. Then we have to figure out if her extreme physical exhaustion is compromising everyday safety, like driving or cooking. And finally, we need to map out our interprofessional team right away, connecting with her oncologist, a lymphedema PT, a social worker, and her employer. Moving right along to Section 2, Clinical Assessment and Formulation. During our assessment, Sarah presents with mild swelling, reduced shoulder flexion, and immense fatigue after just 20 minutes of activity. So we need to deploy a comprehensive suite of tools. We use the COPM to pinpoint her meaningful occupational priorities. We pair that with strict volumetric tracking for totally reliable fluid data, and goniometric kinematics to spot any structural fibrosis. But, we also rely on the brief fatigue inventory to differentiate her physical exhaustion from that cognitive chemo brain. Plus, we do functional observations to simulate classroom tasks. Why? Because a quiet, controlled clinic lacks the absolute chaos of a fast-paced classroom, and we need to see how she compensates. So why is it a massive clinical error to only measure her swollen arm? Well, because achieving stable measurements on an arm means absolutely nothing if memory gaps and an intense fear of recurrence are still preventing her from managing a room full of kids. We have to utilize a holistic CMOP analysis. This is a framework that evaluates the physical, the cognitive, and the environmental factors all tied together. This diagnostic matrix perfectly illustrates the metabolic and vocational collisions Sarah's up against. Think about it. You have a compromised person dealing with swelling and anxiety. You have occupations demanding high-reach self-care and halted leisure activities. She can't even do her gardening right now. And then you have the environment, a super high-energy classroom demanding repetitive overhead reaching, not to mention strict school board timelines pushing her for a full-time return. It's a perfect storm. Let's look at Section 3, Setting Smart Recovery Benchmarks. Notice how these milestones progressively stack on top of one another? We don't just throw her back to the wolves. By week 2, we make sure she's got domestic energy conservation down. By week 4, we focus on biomechanical range of motion so she can physically reach a whiteboard. Week 6, she masters her lymphedema self-care. It's only by week 8 that we simulate the heavy cognitive and physical demands of actual teaching, which finally leads to a modified transition back into the classroom by week 10. Okay, on to Section 4, the Comprehensive OT Intervention Plan. How does this all play out in daily practice? Well, our plan aggressively targets limb protection. For example, she has to avoid blood draws on her left side and wear thick gloves when gardening. We teach her manual lymphatic drainage and how to properly use a daytime compression sleeve. But just as crucially, we teach her the 4 Ps of energy budgeting: pacing, planning, prioritizing, and positioning. To combat that chemo brain, we bring in structured planners and try to cut out multitasking. We even ergonomically alter her classroom, giving her an adjustable stool and switching her to a digital projector so she doesn't have to keep reaching up to write on a whiteboard. And outside the clinic, we have to fiercely advocate for a graduated return to work plan. The school board needs to understand this is a medical necessity, not a casual preference. She starts slow, just 3 hours a day on content prep, 3 days a week with 0 morning supervision. Weeks 3 and 4 scale up to 5 hours, focusing on core instruction with built-in rest breaks. We slowly scale up to full hours strictly based on her functional endurance, never based on institutional pressure. Which brings us to Section 5, Managing Setbacks. Because let's be real, clinical plans rarely go perfectly smoothly. Take a second to consider this. What happens when your clinical plan collides head-on with workplace pressure and a profound crisis of body image? What do you do if your carefully crafted, perfectly scheduled 10-week plan suddenly falls apart at the very first follow-up appointment?
Picture this. Sarah comes into your clinic, drops her compression sleeve on the table, and says, "I stopped wearing this last week. It just reminds me of having cancer, and I feel like everyone is staring at me." And then she drops the real bomb. Her principal is pressuring her to return full-time next Monday, and she is terrified of looking weak to her peers. This is a massive turning point. Her refusal to wear the garment isn't just simple noncompliance. It's a complex, totally valid psychosocial reaction to trauma, and it's being heavily compounded by institutional pressure.
In high-stakes moments like this, you have to be the expert. And the clinical reality is stark. Returning to a 40-hour teaching week next Monday during active radiation is clinically unsafe. Period. A sudden return like that invites a massive lymphedema flare-up and practically guarantees cognitive burnout. So, to salvage the recovery, we have to immediately de-escalate the distress. We validate that the sleeve is indeed a traumatic visual reminder, not just a tool. We explore more comfortable fabrics or more flexible wear schedules to give her back a sense of control. Then, we use role play to build up her self-advocacy skills. We help her reframe these workplace accommodations not as a weakness, but as standard medical recovery tools, just like crutches for a broken leg. And most importantly, we step up to shield her. With her consent, we formally coordinate with her oncologist to secure medical restriction documents, effectively blocking the principal's unsafe demands. We also connect her with an oncology psychologist and a survivor group for peer support. This case is a brilliant illustration of ACOTRO competency mastery. It proves that Canadian occupational therapy is never just about the physical rehab. It requires this seamless integration of biomechanical expertise, stuff like decongestive therapy and energy conservation, with fierce structural workplace advocacy and deep psychosocial support.
So as you reflect on Sarah's incredibly challenging journey, I want to leave you with this final thought. When strict institutional timelines threaten your patient's holistic recovery, how will you use your objective clinical data to step up and fiercely advocate for their fundamental right to heal? I want you to really think about that and keep it at the absolute forefront of your practice. Thanks so much for joining me on this explainer, and I'll catch you next time.